Hello, Renee. How are you? We're on another episode.
Man, and no, these are just clicking along. But yeah, good to be here. How's your spring been with all your planting and all the things you're doing in the farm? Is that going all right?
It was such a wet spring. After a drought, I shouldn't complain about how wet this spring was, but
Yeah.
boy, it was a wet spring. So I've just been discombobulated for the last month and a half, I have to admit.
Well, it has to be hard because you may have quote your plans, but then you don't really get to do those. You just have to kind of wait for whatever happens with rain or not rain. And we had for not having rain for as long as we did, we had a long stretch there of just a little rain, more rain, day after day after day. And that has to be tough for trying to get into a
Yep.
big old tractor in a field.
Yep, just kept messing up the schedule. And so you know how difficult it is between speaking and working and then trying to get the crop in. It was a very long spring. So
Well, luckily now we're into summer, and maybe it'll be interesting to see if it dries out like it does some summers, or if we're just going to keep getting wet. I guess we don't know yet, but we'll see how it goes. So today we're going to be talking about telehealth and talking about some of the challenges with that and some of the opportunities. There's some really great things happening in the world of telemedicine, and then there's some challenges that still happen. And we're going to talk about the different policy things that come up and some of the other issues that we've run into. And then we're going to tell some stories about how things could have gone better in some places after we share some data about what we're seeing in the telemedicine space. So kick us off, Jason. What are we talking about today? What are some of the challenges that we're seeing in that telemedicine, telehealth space?
yeah, well, I think, what we kind of need to talk about is it's complicated, right? That telehealth is a great opportunity, but there's lots of things we have to consider. So, I think what we need to do is kind of run through the list of considerations, right? Because there's a whole lot to consider when we start approaching telehealth. It's not as easy as just saying, broadly, hey, we need somebody. Why don't we just connect with a video link? Sometimes I think telehealth is overly simplified. And I think, as we think about all the considerations, we start to understand why it is such a complicated issue. And then we can start to kind of unpack the policy issues that make it even worse sometimes, because
Yeah.
well-meaning policies can make this so much more challenging when it's already a challenging issue. And we've seen that firsthand, haven't we, Renee?
Yeah. And even trying to get paid for it, right? The billing components of this don't get easy. And so, we've had in Iowa on the books for years that a telemedicine appointment is the same as an in-person appointment. And we did that long ago so that it could help with that billing idea. But there's still these challenges that we're talking about where people only want to pay you a percentage of it because the perception, to your point, is that it's easier. You could do it from home. You may not have to have an office. And so therefore it should cost less to do the service. But when you really want to do the service and do it well, sometimes there's even more cost involved because you might have to have encrypted networks and different things for privacy and some pieces that sometimes they just don't understand or see. So there's just a lot of pieces. But one of the things that I think is really impressive about it is there's a lot of different ways to do it, right? There's not just like one way to do telehealth. So Jason, kind of run down some of the different models of how you've seen it work in the past.
Well, kind of like you just said, where is the site of service? Where's the origination and where's the patient located? It can be so variable, right? It could be
Mm-hmm.
both parties are in their own homes
Mm-hmm.
and a service being delivered, or it could be from hospital to clinic setting, or it could be a person goes to their clinic and the provider's at home. All of those things complicate sometimes the requirements, like you talked about, between insurance, between different laws in different states, depending on where each person is sitting. There's been situations where people go on vacation and their prescriber, they saw them by telehealth. And there's no reason why they couldn't see them in another state, but because they were in another state, they couldn't be seen for a med refill. And so sometimes we have all these requirements that are really complicated. And as we've seen over the last couple of years, it's only become more complicated as more people have really embraced this idea of being more mobile. And being able to do that. So, the first consideration is where is it located? Where is the patient located? Where is the practitioner located?
Mm-hmm.
And all of that can add a level of complexity. The second thing I think about is we have to think differently. So, when you think about a provider entity, it's a different mindset when you're managing people remotely, right? It really
Yeah.
takes the work from home to a new level, right? If you're a
Mm-hmm.
physician working from home, a psychiatrist working from home, a therapist working from home, and providing telepsychiatry services or telehealth services, it's different, right? It's different how you manage your time. It's different how you schedule patients. And so that can be a really hard mindset shift for some folks. We talked about insurance challenges and barriers, right? A lot of that has to do with site of delivery. We talked a little bit licensure, right? It depends on
Mm-hmm.
where you're at. It depends on
Mm-hmm.
on what type of licensure. There's ethical concerns that are new and emerging that we're still trying to wrap our heads around in some
Right.
cases. I think, Renee, you've talked in other episodes about no compete issues, right? And so sometimes there
Mm-hmm.
were there were these legacy no compete contracts, and I think that's been addressed federally, hasn't it?
Yeah, there's been a law recently passed, or maybe an executive order by the president, but the idea is to deal with that non-compete issue. And one story, just so that you can understand the craziness of the non-compete, it used to be depending upon, and this is across all industries, so not just, we're not talking just healthcare, but in healthcare in our state, we would have non-compete where if somebody lived or worked, within say 45 miles or 45 minutes of the location and they left, they couldn't work within that range for so much time after they gave up their job or their contract. But when it came into telehealth, it would then expand into that. So then they couldn't live in that 45-mile range, plus do telehealth in that area, nor could they even move outside the 45 and then have patients within the 45. And it just got really obsessive. And so it was wiping out parts of our state where people literally had to move out of state to be able to practice and use their license. And so those are real down to earth practical issues that we've had in our state. And so it's been a real challenge. But I wanted to go back to one thing you said about, how we have more providers now wanting to work remote. And as we all know, our psychiatrists are aging population, and letting them be able to do some telehealth and telemedicine while retired actually expands our workforce. And so there's a huge opportunity here, and it won't look like it used to. If they're of retirement age, why would they want to be in a hospital setting, doing the 24/7 situation? And so there's reasons to pursue this, because it can actually help us expand and keep some of those folks who have moved out of the needing to even be there every single day, because that's the season of life they're not in, but we could still keep their expertise. And in some of our states, that's a really big deal.
Absolutely. I also think about, and we often don't think about broadband access, especially
Mm,
when we go to rural areas. And so, and I've been guilty of it myself. I've had broadband in my machine shed in rural Iowa for the last 6 years with high speed fiber internet connection. My neighbors 1 mile away from me just got it last year. And so there's still lots of rural areas that don't have fast enough internet speeds to support telehealth or video to the level we would expect it, in this day and age. And so I think, we can't forget, and I think Iowa's been pretty progressive in continuing to move broadband access,
mm-hmm,
statewide. We know some other states have been really focused on that we've been in, Renee.
mm-hmm.
But I think that is a huge hindrance in a lot of rural and remote communities, is not having adequate internet access.
Right. And if you think about some of the current laws on the books for telemedicine, it's still video face to face. And so they're not accepting maybe the phone calls or even and definitely not the things that are not considered real time. So, like looking at the data that you've collected, maybe on your smart device or whatever, they're not using that information because they're not paying for it as it's the same as if you're in an, and they probably shouldn't, because it isn't with the doctor. I mean, I get that, but some of the laws specifically outline that and say that that's not useful, and that causes a challenge. My in-laws were in the north part of Polk County, which is our largest county in our state, and they were in this triangle that did not have broadband access, and they had dial-up internet until we were able to get the ability to do a hotspot with a cell phone once there was,
Uh,
because we had dial up in that little, and there was Polk County. And so, but it was
mhm,
a more rural part, northwest corner of it. And that's been really recent. And so it's
mhm.
not consistent, to your point about how it's, there's good areas of broadband in our state, but there's still gaps. And so if you're thinking about that as like a main medical tool, we're leaving out some people. So you've got to think differently then about that. I know another area we think about for telehealth where it's really can be useful, and then there's some challenges in that crisis response. So Jason, where do you see this kind of tying into crisis, and how do you see telehealth maybe being something that can be useful in that space?
Yeah, I mean, so I think it's a twofold issue, right? One is if we're providing telehealth in a remote area, what happens if something goes wrong? Is
Mm,
there a response in person to support someone who may be experiencing a mental health crisis? And so,
mhm,
that really then speaks to, is there crisis response available
mm,
across an entire state, right? To be able to support the infrastructure of telehealth. And secondly, the other response would be crisis responders being able to utilize telehealth to talk to those
yeah.
professionals during and in the midst of a crisis. And so I think sometimes that's left out of, there has to be the appropriate structures in place to support telehealth, in communities, especially in rural and remote areas. And I don't think that's always part of the conversation. And it really
Mhm.
should be if we're really concerned about a continuum of care, if we're really trying to promote, this infrastructure that supports people
Yeah.
across the continuum of care, then we have to make sure all these components are in place and they all have to fit together like a puzzle. They can't just be kind of thrown up against the wall and be like, well, we have this thing over here and this thing over here. And so oftentimes that's what we see, Renee,
Right.
is these things are created separately,
Yeah.
but they actually have to interlock and work together.
Right. And that kind of leads to our next point that is about it can't be all or nothing, right? It's not going to
Right.
work as a system as 100% telemedicine. And then it's definitely not going to work if you don't have any. And I can share this story, but I've met many, many well-meaning legislators through the years who don't want to support telehealth because they're still under the mindset that somehow that will preclude them from getting in-person people to move to their rural community to do medical care. And our rural communities are struggling with getting professionals into those communities, not just medical, right? But we have problems with veterinary services, with dentists. I mean, you go down the list, it's just harder and harder to get people into rural communities for professional levels of care. But they really just could not see that forest for the trees because they're like, well, if we support this, then we're not going to get doctors in our community. And my thoughts are you may not get them anyway. So at least we would have something to connect your people. And so that's that all or nothing mindset. And so that's
Right.
really been a challenge. And that's pretty recent. That's not like, we can't think about this like back in the 1900s. No, we're talking, in the last 5 years that legislators still are under the mindset is we don't want to promote telehealth because we want people to come work in our communities. Well, we're in a workforce shortage across the country, even in urban areas, don't have the numbers of workers they need for the number of people that live in those communities. And so it's not going to be a short-term fix where we can just find people growing on trees like we talk about. So that's one. But I know, Jason, you always think about like how to find the right kind of model based on what people are looking for. Talk about that some.
Yeah, I mean, I think exactly what you just said. It's about the blend, right? It's not an either or, it's an and, right? And we have to think about how can telehealth support our current infrastructure and support those individuals who we already have in place or support recruitment efforts. We've been in rural communities, and we'll talk about this a little bit in a few minutes, that if they only have one provider, how can we not consider telehealth as a way to support and decrease the burnout of the one provider? And so,
Yeah.
we really need to think about that. It's not either or. We have to use all the tools we have available to us, in this day and age. And it's only the responsible thing to do because that's going to provide better care to our folks. And so, let's talk about data for a minute, right?
Yeah.
Because, we know this is a real deal. And so why are we talking about telehealth? Because the explosion of
Mm-hmm.
utilization of telehealth, since 2019, since we all know what happened in that 2019-20 time period, it changed a lot of things,
It sure did.
especially when it comes to healthcare delivery, right? And so in
Mm-hmm.
2021, 37% of adults utilized telemedicine in the past 12 months,
Right.
right? That's a huge percentage of folks who utilize telemedicine in one way or the other, whether it was physical health care, mental health care.
Mm.
That kind of tells me it's something we have to consider. It's not just a passing fad.
No.
It kind of goes back to the computers that'll come and go. This is not something that's going to come and go. It's part of healthcare delivery now. And so how big a part of healthcare delivery, I think we can figure out, right? That goes back to the blend, but it's part, right?
Yeah. Think of that newfangled internet. It's gonna, just
Right,
come and go. And you're just
right.
like, it's not really gonna do that. But During the pandemic, telemedicine was just a lifeline for so many people because places that provided medical care had to shut down for periods of time, and then or they got to just doing just the minimal that they could have certain people coming in to deal with those illnesses and weren't able to do other things. And so telemedicine really exploded and it became an opportunity for people to get care that they needed. And then they found that it worked, right? There's a lot of it doesn't replace face to face. It accents it and it gives you extra options. And so the data, we're talking about it increased with age. I know my parents live in sort of a medical desert, and it's as they age and it gets more complicated to get out of the house, it's been a lifeline for them to be able to, they can't do all of their appointments that way, but they have a specialist that's 3 hours away. And so they make them come in person, but only once a year. So the other ones can all be video conferences and video chats. It's just an amazing opportunity for them where they just literally physically couldn't probably pull off the face-to-face all the time just because of the distance to places. And so it talks about people that with increased age used it more. The data shows that's true. And it's even higher among women compared with men. And one of the thoughts about that for women, oftentimes they have their kids. And so, you may have kids in childcare, and not that men don't take care of kids, they do, but sometimes women get that extra burden and it's really hard. We've got friends, trying to find, who can watch my kids so I can go to this appointment and juggle this or that. And parents trying to work, and maybe the dad has to come home from work to have the kids. And so it's not as easy as that all sounds. So telemedicine, again, is just one tool that you can, if you're sick, or maybe you're sick and the kids are sick, you don't have to drag out all the sick people. You can just take care of stuff at home. So that's data that, saying that among women, it's at 42%. That's really high, and it's higher than men, but even men where it's over 30%. And that's a big deal.
I think it is important, though, to acknowledge that there is some equity issues when it comes to utilization of telehealth. The use of telemedicine increased with education level and family income. Telemedicine was more likely to be used in non-urban areas. And we can see when we look at kind of breakdowns that individuals who were, well, actually, non-Hispanic white individuals used telehealth more frequently, right? Than others. And so, we do have to consider, is telehealth actually just being accessed by those with means at a much higher rate? Is it an insurance linked issue? I think those are questions that we need to ask ourselves when we think about healthcare equity and healthcare access for all.
Yeah. And we're going to put in the show notes where you can get some of this data for yourself if you want to dive in and see who used it more. And this is pretty recent data for, as far as data is concerned, we're in 2021 on this. That's pretty recent. So it's good stuff. And so it's sort of post-pandemic, gives you an idea. So Jesse, let's talk about some of the ways that we've seen telehealth be helpful, or even when it wasn't. And I know one of the contracts we worked out in another state to the north, really far north, they had lost their psychiatrist due to an untimely death. And I'll talk about that. What was their kind of their thought process with telemedicine and all of the things that were going on there?
Well, it was interesting because they were very much against telemedicine. And it was unfortunate because, their psychiatrist had just died, and he was the only psychiatrist in a 4-county area, right, across a very large geographic region. And we asked the question of, could telepsychiatry be a gap solution, right? Could it fill this void that you're now experiencing in your emergency room to manage some scripts that maybe some of the other physicians aren't comfortable with? And I think the answer was pretty clear. Yeah, we don't like that. Wasn't it, Renee?
It kind of was. And what was really tough about that is they were getting people constantly in their emergency rooms that needed a psychiatric evaluation. And what was happening that was incorrect was they were basically giving them a medical checkup and then letting them leave the building and not really addressing the psychiatric because they weren't prepped for that. And, they could have easily just had a telemedicine program where they could have had at least the evaluation in the ED. And in crisis services, telemedicine has been so huge as far as opportunities to just have access in those things, because you just don't have the number of bodies to just go everywhere to deal with every crisis, and nor do you need to. We've talked about this in the past, but when people use the hotline, I think it's only like 3%, 3 to 5% that need a mobile response. So there's a whole lot of people that don't need an expert to be in their face when they're in crisis. That's a whole lot, right? That's the largest percentage. So it's just the minority people. And so to have a plan for how you could access for that 3 to 5% that are in that crisis that need the psychiatrist, that's super important. And so it was really disheartening in those conversations with that particular emergency department because we couldn't get them to see the value of just having the crisis part covered, which is just really sad.
And we've seen the value of that. One of the partners we work with provides psychiatric access in critical access hospitals all across the country. And we see how successful that can be, that, there's some really great groups that put groups of psychiatrists together that deliver these services on demand to emergency departments. When that happens, when someone walks in at 3 a.m. and they need a psychiatric eval, they can access that eval within a very short amount of time, and then have, some continuity of care, direct people to the right places they need to be. So we've seen success, in that model, in those emergency rooms, in those, really rural and frontier areas where they don't have access to specialty. And so, I struggle when we think, that's a great opportunity to blend, right? That you don't have all the specialists in some of these rural areas. This is a great way, especially as we think about mental health and we think about mental health crisis and where do people generally go if they're not feeling well in a rural area? They're going to show up at the hospital. And so our hospitals, this hasn't been always an area, especially in our rural critical access hospitals. This hasn't always been a strength of how to manage. And so I think this is a great solution in those situations.
Right. And you mentioned before about if you have the one psychiatrist, and this could also be support for them to avoid their burnout. But I was also thinking, as myself being a lower level professional, if I were the one that is at the hospital, I'm that social worker, I'm that mental health therapist, what an awesome opportunity to consult. So I might be able to do the hands-on, but there's stuff that comes in sometimes where I would not know what to do. And so to be able to have that telemedicine consultation. So even if I'm the one as the professional that gets to call the psychiatrist and get a consultation, or to confirm the medication choice I want to use, or to confirm the next step for this person or whatever, it is what you said about burnout. It's that, just think how stressful that has to be if you're the lower level person, and maybe you're even an ER doc, but it's not your specialty, right? So it's not just protecting maybe the one or two psychiatrists you may have, but it's protecting your ER docs that are put in positions where that's not their specialty, that's not their jam, and they're supposed to make the best decisions they can. So you could have this telemedicine consultation option so that you could talk to whoever. And even if it's not, we think about this about the psychiatrist, but child psychiatry is even harder to find. Or you think about specifics for elderly and the geriatric psychiatrics, right? Those are hard to find. And so that's a universe that's available through, like you're talking about our partner, that it's available. They have those specialists that you only need to talk to when you have that specific issue. But how awesome to help the staff who is on the ground going to help it. And so it really can reduce that stress in your emergency department and the burnout.
And I love that doc-to-doc consult piece. I think so oftentimes that's underutilized and not a consideration. When we talk about telehealth, we immediately think about serving a patient. But if we could just support the medical teams, whether it be primary care or emergency room docs, that makes a huge difference. I think, it makes me think about Missouri. They have a really great statewide Project Echo going on right now, and that's doc-to-doc consultation. So that their primary care physicians, especially in those rural areas in southern Missouri, down there, in the heel of the boot. So those, that's one of the most underserved areas when we think about rural. And so that way, those primary care physicians can treat things that are well beyond what they learned how to treat. Especially when it comes to psychiatric conditions. And I think sometimes we're not taking advantage of those types of support projects that can really help the physicians we already have in our communities, right? It can help provide them the support so that they can serve more people. And that actually decreases in our need to bring other docs in using telepsychiatry. It supports the infrastructure already in communities. And that's the blend that sometimes our legislators and others don't see. They don't see the bigger picture of how this supports that entire continuum. It creates continuity of care. It creates a stronger medical community that we need to serve people.
Yeah. And one more thing I just wanted to bring up, because in our work up in the Dakotas, we realize, especially in the Native American communities, they were really struggling with broadband. And there's a couple of things that where they used the infrastructure dollars that were available at the federal level and at their state level for broadband to create kind of hotspots, if you will, because they couldn't get broadband to everybody, but they could get it to certain locations so that people could come to that location and then access medical care. And that's a huge deal. So sometimes we also think from the broadband perspective, it has to be every single house, everything has to be equitable. But if you have places where people can go to access and utilize those tools, that also can help, especially in those frontier states where it's just so many miles between people and so many miles between towns and resources. And so there are this great projects happening around our country trying to help. And so it is that bigger picture. It's just think of that. Those sites that they create for broadband doesn't have to be just for medical, right? It can be used for education. It could be used for all kinds of things. And so it's really thinking about how do we work as a system overall to get people the care that they need. And it's bigger than just healthcare. And so there's some really exciting projects going on out there. Did you want to comment on any other ones that you've heard of?
No, I think the only thing I'd leave us on is also thinking about this is a great way to help us when we think about equitable access and care. And so, we think about language barriers, we think about how do we
Yes.
how do we serve people, in an underserved, minority populations. And I think this is a great opportunity, right? We can link folks together and decrease some of those barriers that keep people from accessing care that can't facilitate the care that someone needs. And so, when I think about culturally competent care, this is a huge opportunity. And so that creates another layer of
Mhm.
complexity to telepsychiatry or telehealth in general, but it's also a huge opportunity because this
Mhm.
can definitely fill some gaps, when we think about how do we serve those communities within our community.
And just to continue on to that, there's some translation options and things available too when you're doing video chats. And so it can actually help break down some of those barriers. The word to word translations are a little
Right,
strange sometimes, but it's better than nothing. And so
right.
again, just using the technology, there's so much available out there that people could use. So now we're going to talk about the recovering politician self-care policy of the week. And this one's really simple, but we're really bad at it. It's called asking for help. Do you know that in various seasons of life, things happen that you just have no idea what's going on? I don't know if it's happened to you yet, but you get to a place and you're like, well, I've never been here before. I don't really know how to deal with this. But guess what? There's people all around you, maybe older than you, maybe, gone through the season of life before you, that'll have some ideas. And so it's like, it doesn't have to be a professional for help. This depends kind of what's going on in your life. But there's always times when you're like sitting there thinking, I just have not one idea what I'm supposed to do about X. Well, that's a pretty good time that it's time to like kind of, maybe poll somebody else. Do you know somebody that knows something about this? And almost always people will be like, I just had this conversation with so and so, and they may have a resource or a reference for you. But sometimes we just have to get out of our comfort zones. For the folks in my life, I've got some family who are really not good at this, think they should just know everything, do everything. One is exhausting, and two, you can't know everything. And the world throws surprise curveballs at me sometimes. And what are you going to do? And so just a reminder, it's not a weakness. It's actually pretty smart. If you can you can network with people and use them to help get the answers that you need, that makes you a pretty smart person. So just reminding everybody, no shame in your game for asking help, but that's the self-care tip I'm thinking of this week. Jason, did you have any ideas in that realm?
I did, and I agree with everything you said.
Look at that. Write that down, everybody. He's agreeing with me. Look out. Well, today we talked about telemedicine, telehealth, and there's a lot of challenges still in this field, but there's so many opportunities if we continue to move forward. There's so many ways we can better our healthcare system and make it part of a system that not only helps patients, but can support our existing infrastructure and our providers. And so there's really creative things happening out there. And we're just thankful that you guys are listening to us. We put some stuff in the show notes where you can see the data on how this trend is not going to go away. And so we hope to see you next time. Talk to you then.